Welcome, everybody. I'm excited today in this unusual format, unusual at least for doing this meeting, having done this meeting so many times. But welcome virtually, at least, to our meeting today. I'm so excited that we were still able to have Dr. John Corrigan as our keynote speaker. John and I have known each other certainly for a long time and worked together on many projects. He's really considered a leader when it comes to brain injury medicine and brain injury rehabilitation. Dr. Corrigan is a professor in the Department of Physical Medicine and Rehabilitation at Ohio State University in Columbus, Ohio, which apparently is where he's coming from right now, or where he'll be projecting from. He's the director of Ohio Valley Center for Brain Injury Prevention and Rehabilitation. I know he spends a lot of his time with the preeminent journal, the Journal of Head Trauma Rehabilitation. He's the editor-in-chief of the Journal of Head Trauma Rehabilitation. Dr. Corrigan has been the PI and co-PI of the Ohio Regional Traumatic Brain Injury Model System since 1997, and chaired the executive committee of the TBI Model Systems project directors from 2007 to 2017. He certainly played a tremendous role in bringing the model systems forward over those many years. He's the director of the Ohio Brain Injury Program, which is the designated lead agency in the Ohio for TBI policy and planning. He's a member of the board of directors of the Brain Injury Association of America, and has previously has served national organizations, including the Commission on Accreditation of Rehabilitation Facilities, also known as CARF, the Control Center at CDC, the Veterans Administration, and the U.S. Department of Defense, and the Defense Health Board. He has more than 160 peer-reviewed publications and has received many awards for his service in research in brain injury rehabilitation, including the Brain Injury Association of America's William Fields Cavanis Award, the 2007 Robert L. Moody Prize, and the Gold Key Award from the American Congress of Rehabilitation Medicine. We are very fortunate to have Dr. Corrigan joining us today. Today, Dr. Corrigan's presentation is Traumatic Brain Injury as a Chronic Health Condition. Please welcome me with a round of applause in joining, please join me in welcoming Dr. John Corrigan.
Well, thank you so much, Brian. I don't know what a virtual round of applause sounds like. That was me.
There we go.
Yeah. And let's get my screen up here. Chris, if you want to. There we go. And here. And let's get this started. There we go. Great. I hope that looks good. Well, I'm very pleased to be providing this keynote address for the Brain Injury Alliance of New Jersey. I would much rather be in New Jersey than just be doing this remotely, but we are all adapting. Not everyone knows that I did a good part of my growing up in New Jersey. Graduated from Somerville High School many years ago. So I was looking forward to the trip back, but we'll settle for having the opportunity to speak with you virtually today. As Brian indicated, the topic is traumatic brain injury as a chronic health condition. You're going to see some of the roots of where we are today span almost 20 years. With the last 10 years being a tremendous amount of developments in terms of awareness of TBI as a chronic health condition. But you will also see before we finish that we have another decade at least of hard work to do to really turn the awareness of this phenomena into changing the lives for persons with brain injury. For our survivors and family members who are listening, the first part of this talk may sound a little bit ominous because we're going to be talking about some of the downside But I hope you'll see before we finish that this is really a talk about optimism and what we can do, the things we have control over, and what we can do both as professionals and individuals with brain injury and family members to make our lives better. So I don't have any direct financial conflicts of interest. I receive funding from NIDLR, mostly for the model systems, National Institutes of Health, and PCORI, the Patient-Centered Outcomes Research Institute. And as Brian said, I am a member of the board of directors of the Brain Injury Association of America. So the traumatic brain injury model systems, most folks know this, has been around for a little more than 30 years now. Every 5 years, there's a recompetition of what centers are in and what centers are out. So we have the currently funded 16 centers, as well as several centers that are just doing follow-up interviews, and our previously funded centers. In 2008, the NIDLR, then NIDR, signed an interagency agreement with the Department of Veterans Affairs to add in the VA TBI model systems, of which there are 5. And we meet and collaborate together, even though the actual data sets are very parallel and kept, but the data is kept separately. I mentioned this because much of what I'll be talking about initially in this talk comes from data from the TBI model systems national data set, which is a longitudinal data set, and they created to allow us to be able to see what happens over a person's lifetime after moderate and severe traumatic brain injury. And while these numbers are a year old now, that national database has over 17,000 individuals who have given us permission to get data about them and continue to follow them up. We now have that actually should be year 30, not year 25 at the bottom, that we have 13 individuals who are 30 years post-injury. When the model systems was expanded from 5 to 16 about 15 years ago, we really started to see an increase in the number of cases. And so we are, because of the numbers and the low attrition rate, meaning that we are following up, we know what's happened with almost everyone, that we're really able to look at brain injury now as a longitudinal or look at it longitudinally using longitudinal research models and analytic approaches, when before we kind of had to look at everything cross-sectionally. Well, of people we know who are 10 years post, this is what's happening. Of people we know who are 5 years post, but we didn't know what was happening continuously over that time. And it's a very different picture. And in many ways, the story of TBI as a chronic health condition, the recognition of it, is about being able to see the things longitudinally rather than cross-sectionally. A few years back, a series of studies were done to look at how representative this data set is of everybody who gets, at least all adults, persons 16 and over in the United States, who receive acute rehabilitation for a primary diagnosis of traumatic brain injury. And those studies indicate that indeed it is very representative. A slight tendency to have a bit fewer older adults, which was a population that was growing dramatically through the first part of this century in acute rehabilitation for TBI, but so very close that with just a small amount of weighting, we are able to now make national estimates of what's happening to everybody who receives acute rehab for TBI in the US. That capability led to a project that was an interagency agreement between the Centers for Disease Control and Prevention, CDC's Injury Prevention Center, and the now National Institute of Disability Independent Living and Rehab Research, which is where the model systems are funded. Those two bodies came together and formed an interagency agreement to be able to look epidemiologically at persons with brain injury who receive acute rehab. One of the first projects seemed pretty simple at the time. We said, well, how are people doing 5 years after their traumatic brain injuries, these brain injuries that require acute rehab? We thought, just being able to describe that where people were 5 years later would at that time be a tremendous advancement to the field. That project eventually resulted in this study, which is in the Journal of Head Trauma Rehabilitation. But it took a little winding road to get there, and that's what I want to share with you now. So what we did is we took model systems participants who were admitted from 2001 to 2007. This was 2001 was the first time we had national data for who's getting rehab, so it allowed us to weight to the or make estimates about the U.S. population. And we looked at them 5 years later. And the good news was that for almost 85%, there was a known outcome. We knew where they were at year 5. So with very few missing data or loss to follow-up, we felt pretty confident about our ability to characterize what life would be like 5 years later. The bad news was that we discovered for 1 in 4, the known outcome was that they had deceased. And while we had been aware for a little while and suspected that, more than suspected, knew that there was an effect on life expectancy for having a traumatic brain injury, we didn't expect that it would be of quite this magnitude. This is what it looks like, and this slide is showing you that 21.7% of those we estimate nationwide would have deceased within 5 years. There's a tremendous relationship with the age at injury. That's what's along the bottom here. But I will show you in a moment that even though, as we expect, the older the person at injury, the more likely they may decease, because that's true in the general population, that the excess mortality here exceeded what would be expected for all age groups, except those, the very oldest. So, this this led us to another part of the project we were doing with CDC and NILR, and to do a deep dive into life expectancy. And this was an article that was led by Cindy Harrison Felix. And not to hit you with too many numbers, but we had a very large group of participants from the model systems, representing almost 20,000 person years post-injury of data, weighted to a national population of more than 150,000 individuals. And we compared mortality for those individuals to those in the general population, matched for age, race, and sex, using both 2005 and 2010 mortality data to make that comparison. So this is what we found. And to cut to the chase, if you look out here, the standardized mortality ratio is essentially an indicator of how much more likely a group is to die compared to, and in this case, with same age, sex, and race general population, members of the general population. And so for all participants, and so meaning all individuals receiving acute rehabilitation for traumatic brain injury, they were more than 2 times as likely to expire if they'd had the brain injury. If you were alive at 1 year post-injury, it was a little bit better, but you were still 50% more likely to die due to that. When we looked at age at injury, as I indicated before, you see the standardized mortality ratio in red there. All of those up to age 85 are excess mortality, meaning more likely to die than a similar age group. It was only those in the 85 plus range that were not more likely, and indeed were actually less likely, which is a bit of an anomaly. When we looked at cause of death, it was really quite varied. Here down the left side, you see based on death certificates, the indicated cause of death. And the standardized mortality ratios there, mostly in red, show how much more likely you were to die of that cause than, again, age, race, sex matched individuals. So, up at the top there in seizures, you see you're 50 times more likely to die from a seizure if you'd had a history of traumatic brain injury, moderate severe traumatic brain injury. So that's probably, given that a very high ratio, it probably means there is something about seizures that's very directly related to the traumatic brain injury. And I think we know that, the kind of damage that can happen to the brain can result in seizures. And so, the odds of that are very high. But down here on the bottom, for circulatory system problems as a cause of death, this would include strokes, for instance, that you see there is an excess mortality. You're 40% more likely. But in this case, the numbers are quite high. We have, some 340 deaths from circulatory disorders. So when we look at these numbers, what we realize is we have some things that seem to be more directly related, other things more indirectly. Some things cause a larger magnitude of deaths and some smaller magnitude. And from these data, at least, the only condition that where there was not cause of death, where there was not excess mortality, were digestive disorders. You might see the accidental poisoning there, some 10 times more likely. I don't know if it jumps right out to you what accidental poisoning is about, but among those deaths, both opioids and alcohol were highly related to that accidental poisoning. So again, oh, and I wanted to say, I forgot I had added this, that was mortality based on the model systems and US population estimates. But it does appear that mortality there is greater mortality even with less severe injuries. This was a study out of Scotland, where they looked at individuals who were hospitalized but with just mild traumatic brain injury. And for those who were injured before the age of 55, down the middle here, if you'd had that mild head injury, you were more likely than people with other injuries to die in the next 15 years, and 4 times more likely than community controls, meaning same age, sex, who had not had any injury. If you had the injury after age 55, it still was accelerated, not quite as marked compared to those who had other injuries, but significantly greater than the community control. So this relationship with mortality may not only be an issue for those with most severe injuries, but at least mild injuries that cause one to be hospitalized, also brings excess mortality. So just to recap what we know about mortality, that you are more than twice as likely compared to same-sex, age and race, ethnicity, members of the general population. If you've had a moderate severe traumatic brain injury, it really is all age groups, except maybe the very oldest. There's a very wide variety of causes of death, which is actually a clue as we are thinking, as you'll see in a moment, when we're talking about traumatic brain injury as a chronic health condition, what is behind so many different causes of death. And it's not just limited to those receiving acute rehab, but at least hospitalized mild as well. So that was our kind of the side track we went on once we realized that at 5 years post that someone in 4's outcome was deceased, but we still wanted to know what would it be like living with a traumatic brain injury 5 years later. So we reweighted the sample and just looked at people still alive 5 years later. And I'm going to show you a few slides then from this work. Keeping in mind, these are people all still alive. So this first one shows who's institutionalized. And again, just to kind of orient you, along the bottom here is the age at the time of injury. Not the 5 years later age, but the age at time of injury. And for you fellow data wonks in the audience, if you want to know what kind of confidence intervals to think about, essentially any difference of more than 2% is probably a significant difference. And I have not added them confidence intervals into this schematic, but just kind of keep that in mind. So what you're seeing here is that of the 12% who are institutionalized, it's much more likely those who have their injuries older. Although, there's a real bump even in what I now consider to be a relatively young age of 50, but in one's 50s and 60s, there is a real bump in likelihood of institutionalization. This is primarily nursing facility, and which then gets accentuated in the later years. Some, essentially 1/3 at 5 years post-injury required assistance in at least one area of physical functioning. And you see here again, there's a very marked age relationship, though still everyone from 16, injured between 16 and 50, some 14, 15% had at least one area of requiring assistance in physical functioning. That then increased dramatically as time went on. This, again, we might not be too surprised by this, particularly thinking about the effects of the injury interacting with changes in function with normal aging. Little different, very different picture by age, at least, when we looked at those who were misusing alcohol during the 5 years since injury. This was more a younger person's sport, obviously, with some 14% overall, but 1 in 3 to 1 in 4 in the younger age groups. I will add that another analysis, a separate analysis, when we looked at older adults who had resumed alcohol, even though they're a lower percentage, the effect on outcomes was very, very significant. So it's less prevalent, but more debilitating. Some 8% of individuals, based on self-report, had moderate to severely depressed mood 5 years post-injury. And here you see still another kind of age distribution, with those in their 40s in particular twice as likely to be reporting the severely depressed mood. And this going down actually some in the 70s and older. That 40 to 50 year group is someone is an age group in the general population that there's been concern about because of high rates of depression and suicide, and maybe interacting with persons with brain injury as well, manifesting for us as well. We looked at just the extent of disability, and this was whether or not one had a moderate or severe disability. This was based on the Glasgow Outcome Scale Extended. Basically, to be in the moderate or severe categorization, you are needing some kind of assistance or supervision for at least part of your day. But you may have, in the moderate area, you may be able to be on your own for a considerable amount of time, but maybe need assistance with bathing, for instance, or something like that. And generally requiring some assistance to be out and about in the community. And here we're seeing that almost 60% of the persons still alive at the 5 years post have moderate or severe disability. Again, this doesn't mean one is completely, doesn't by any means mean one is completely incapacitated, but still in need of some assistance. There is a bit of an age gradient here, but not maybe as pronounced as we might expect it to be, with the highest in the kind of a bimodal distribution in the middle age and older adults having the highest percentage. When we looked at this, one thing that occurred to us was, well, this is how they're doing 5 years after, but how's that compare to right after they came out of the hospital, that earlier in their recovery. And so what we did is we compared the 5-year disability status to, in most cases, the 1-year post-injury disability status. If we didn't have that measure, then we used the 2-year. And we had actually quite a surprise when we looked at that. And this is what you see here, that almost 40% of those alive at 5 years had actually declined in their disability status from 1 year to 5 year. This was much higher than what we expected, and was certainly a clue for what is to come in terms of talking about traumatic brain injury as a chronic health condition. The other thing I want to point out here is that this was regardless of age, essentially, that all age groups were almost equally as likely to experience this decline from year 1 to year 5. The research team, did some speculating that we at the time about what these sources of deterioration might be. One thing is the thought that, what I think we're more familiar with these days, that traumatic brain injury may trigger some kind of progressive degenerative process, meaning a degenerative disease like Parkinson's or Alzheimer's. The one we're hearing a lot about, of course, is chronic traumatic encephalopathy, as it might be related to repeated injuries from sports or exposure in military service. There's a pretty decent support for the relationship with Parkinson's. Alzheimer's is more complicated, but certainly all dementias, there's a relationship. But it is quite clear that while we don't know the prevalence or frequency of these various degenerative diseases resulting from traumatic brain injury, it is not 38%. It is not of the population. This is not, or of the brain injury population. This may account for some cases, but would not account for the prevalence that we observed. Well, another thought is that there's a interaction between losing functional skills, motor skills in particular, but also cognitive skills, and from the injury interacting with changes that are part of normal aging, and that kind of accelerating the aging process and increasing poor health. And that certainly seems consistent with a number of findings. Another thought is that we know that endemic to traumatic brain injury, for many, there is damage in the frontal areas of the brain or wherever else the brain is injured. That can lead to problems around impulsivity and disinhibition, and that poor self-regulation then can lead to behaviors that may be a source of death or further disability. Drinking more, using drugs, taking risks that result in additional injuries. Maybe that's some of the deterioration we're seeing. our colleagues at CDC offered what we now know, as kind of the social determinants of health. But we know that the traumatic brain injury brings with it for many significant financial hardship, and with reduced financial resources, there is an effect on health just in terms of access, as well as ability to engage in healthier behaviors. And what the research team in general concluded is that we probably had all of the above, that all of these different sources of change could be contributing to the deterioration that we were seeing. But bottom line, from looking at these data, it was quite obvious that traumatic brain injury is not a static condition, the way we've been thinking about it, where you have an injury, you go through a period of healing, you improve. That obviously in more severe traumatic brain injury is a matter of years, not just months, but that at some point, there's, kind of reach a ceiling and you're stable. And certainly for less severe injuries, that's how the medical field has viewed TBI. But these data suggest that it's one dynamic, that things are changing, particularly in this 5-year period, and we now know longer. But also that that the change is marked by a likelihood of things getting worse, whether it's dying or a decline in functional abilities. So only, this is when we added everyone back together and put those still alive at 5 years together with those who had died over that time. That's where we got these numbers, and it was the minority of individuals were static, stayed the same. And of course, what I think for many of us, this kind of recognition, begged is, how do we move more people into that column on the right, the 26% who had improved? And that's really what the rest of this talk's going to be about, is how do you address then TBI as this dynamic chronic condition that has the tendency, if not addressed, to make things worse. This was not, I don't want to pretend that the study we were looking at from the model systems was the first time this was acknowledged. There was a 2009 Institute of Medicine report. It was being done for the VA, but it looked at all traumatic brain injury. And it was the first place that kind of sounded the alarm that, there are long-term lifetime changes, some very remote from the injury, and in particular interacting with normal aging, that can cause decline later in life. Brent Mazel and Doug DeWitt published in their study that as talking about traumatic brain injury as a disease process, not an event. They were talking about the same kinds of issues that the data we just looked at suggested. Flora Hammond and I, in 2013, published a commentary about traumatic brain injury as a chronic health condition. The Galveston Brain Injury Conference undertook over several years, was looking at the lifelong effects of traumatic brain injury, and coined the term chronic brain injury. And they didn't limit it to traumatic brain injury, but they're saying that it can persist and progress over an individual's lifespan. And this quote goes on to say that it requires lifelong management as a result. Recently, a group of us working with Brent did an update of the Mazel and DeWitt article. This was published in Brain Injury Professional, where we kind of revisited, based on data since, this concept of TBI as a chronic disease. And no question that the data since have just supported further Brent's conceptions and ours out of the model systems that this is that TBI should be thought of as a chronic health condition or chronic disease. So what does that mean? All right, we've changed our perspective. We recognize it's dynamic. We recognize if left alone, 2 out of 3 folks, that dynamic change is not going to be in the right direction. But how do you make the course different than that? There was an Institute of Medicine report in 2010 that actually kind of foreshadowed what a proactive approach might be, and it was recommending to the VA actually, because that they were going to have lifetime responsibility for particularly our military service members who were injured in Iraq and Afghanistan, that they should be thinking about a proactive approach. And they describe some of the dimensions of that. The first is that you are proactive. You prospectively, clinically monitor how folks are doing, so that you can do early detection of the development of any complications and intervention, hopefully, if it's something that can be intervened upon. They said that the VA needed to identify what preventive interventions could be done. So, even before a complication arises, is there something we can be doing to prevent that from occurring? So what kind of preventive interventions for the high incidence or high risk complications? Training and self-management. Not enough can be said about self-management. We could do several days training on self-management, and we probably should, and hopefully maybe soon will. But self-management is not just that the individual and family member are made partners in this proactive management, but indeed, I think ideally lead the process of proactively managing traumatic brain injury as a chronic health condition. There's got to be access to medical care that's easier in the VA, that has lifelong responsibility for service-related injuries. But as complications develop, it does no good to have identified them if you can't treat them. And there has to be access to rehabilitation services to essentially re-optimize functional abilities. And at the time, this, I think, was a little more avant-garde than it is now, with Medicare at least changing to recognize that rehab services can be provided to prevent decline. But the idea here is that we have given a lot of attention to rehabilitation early after the injury, but if either naturally over time or in conjunction with normal aging, there is a decline in functional abilities, we need to be able to re-optimize, to bring somebody back to their optimal level of functional abilities, because we know that in the general population, for everybody, that the better your functional abilities going into the aging process, the longer you will be healthy and the longer you'll be independent. So these were the components that the Institute of Medicine recommended to the VA. And I think they provide a awfully good kind of roadmap of where maybe we should be going for the civilian and veteran in the U.S. healthcare system. So I'm going to circle back to this slide about possible sources of deterioration, and just starting with the second bullet, looking at loss of functional independence. As I've just said, that is not a given. That we can, through personal behavior and rehabilitation, optimize functional independence. The next bullet, the kind of disinhibition that might happen as part of frontal lobe damage can be addressed with methods such as cognitive remediation or other kinds of systematic programming. Financial hardship may be the hardest to address, but it is certainly reversible. It's not a given. And back up at the top, even thinking about TBI triggering some kind of progressive degenerative process. We don't know why or how TBI triggers these processes. For instance, one hypothesis is it's inflammation, and that inflammation that is needed early after the injury, but should then decline, instead persists, and in its persistence is causing other processes that lead to the neurodegeneration. Well, if that were the case, we don't know, but if it were the case, there are things one can do to address inflammation. So I would like to label this list, rather than possible sources of deterioration, reversible sources of deterioration. And that's really what a chronic disease model of addressing traumatic brain injury would do. It would be to try to get at through kind of a multifaceted approach, get at some of the causes of this deterioration. And so what I thought I would do with the remainder of my at least talk this morning is kind of go through what we know or don't know, and it's unfortunately going to be more what we don't know, to be able to really do evidence-based chronic disease management, to really be able to make these reversible sources of deterioration. Now, any one of these next 5 or 6 topics I'm going to raise could themselves be an entire presentation. So I hope you'll excuse me in advance that this isn't too brief a consideration. So if you're designing a disease management approach and you want it to be evidence-based, one of the first things you would need to ask is, which brain injuries is there this increased risk for negative outcomes? We know brain injuries range everything from, having your bell rung, from, hitting your head on the cupboard, to, very severe traumatic brain injuries that we see in rehabilitation. You would not, initiate a disease management protocol for the entire range of brain injuries. So, which ones, really have this increased risk for negative outcomes that then should result in a proactive disease management approach. We can kind of back into it a little bit, but just as a spoiler, we don't know the answer. But this is the Center for Disease Control's most recent, it's 2013, injury triangle of deaths, hospitalizations, emergency department visits, and then that kind of unknown, those who didn't received other medical care or no care at all. Of course, we suspect that it looks a bit more like this in terms of total incidence. But what I have been talking about this morning with the data from the TBI model systems is really this part of the triangle only. That's the proportion of the total triangle that receives acute rehabilitation for a primary diagnosis of traumatic brain injury. I know you may be surprised at that, but the numbers are not as large as we sometimes think, though large enough, certainly. But is that enough? I mean, the numbers we just looked at, with 2 out of 3, experiencing decline in the first, or 50% experiencing decline in the first 5 years, I would say certainly those who receive acute rehab for primary diagnosis of TBI should be in our disease management approach, under that tent, receiving that care. That is worthy of initiating a disease management approach. But whom else? I apologize that this is so much data that I'm going to do so little with, but this is from a study done in Colorado, looking at the adults in Colorado, their worst TBI in their lifetime, anytime in their lifetime. You see it kind of goes down from blue to the orange, which is individuals with no severe injuries. And on the left there, that activity limitation is you're more likely to have it, certainly with the more severe. But your increase for having an activity limitation actually starts, with even a milder TBI, particularly those with loss of consciousness, 2.5 times more likely to have an activity limitation later in your life. These data aren't causative. We don't know if it's causative. We just know it's an association. On the right, you see for poor physical health that certainly to have a more severe TBI increases the likelihood of poor physical health. But even with a mild TBI with no loss of consciousness, there's an increased risk of poor physical health today. So it's more than just those moderate and severes is what this slide is telling us that may be at risk for activity limitations or poor physical health. Some data from Ohio, again, apologies to have so much on this slide and doing so little with it, but over here on the right, what you see is the association between a worse TBI with being mild with less than 5 minutes loss of consciousness, mild with 5 to 30 minutes loss of consciousness, or moderate severe, the odds of now also having a disability from any of the sources that you see to the left there. So your chances actually are doubled with any loss of consciousness, and that even having 5 to 30 minutes loss of consciousness, your odds are the same as those with the moderate or severe. Again, not causal, this is associations, but the point of these two slides is to say that just focusing on individuals who have had acute rehabilitation for their traumatic brain injury probably is not enough, that there is a larger swath of the brain injury population that will likely need a disease management approach. I'd like to suggest that maybe that 250,000 plus or the additional 250,000 who are hospitalized with a traumatic brain injury may be limited to those where it's the brain injury that is the primary driver of the hospitalization. You can have a very light traumatic brain injury, mild traumatic brain injury, but be in because your foot was also crushed. But that we be thinking eventually not just about those who go on to acute rehab, but others who come into the hospital and go home from there, maybe needing a proactive management approach. So that's the first question, unanswered, as I warned. But the one answer I think that we do have is that for those who go into rehab, we should be thinking about proactive management after. Well, a second question is, so what pre-existing conditions, meaning other kind of comorbid health conditions, require management? What does a person bring to the injury that then after the injury, we have to be more aggressive in managing? And a related question is, what about those conditions that develop after? Especially those that might be able to be prevented if anticipated or detected early, et cetera. So how are comorbidities before or after injury playing into long-term outcomes, and what can we do to be more proactive about addressing them? There was a series of, a study done by the TBI model systems recently looked at people up to 10 years post-injury And it was basically asking this question: how do other comorbid conditions affect kind of the trajectory of your recovery over time? And here, for instance, what we're seeing is hypertension having at any time in your life, meaning before or after injury, and its effect on your motor function from the FIM. And the green line are those who never had diagnosis of hypertension, and the red line are those who did. Overall, you can see both lines are declining as time goes on. And these were people alive at 10 years. So um, uh, uh, similar kind of dynamic as what we were just looking at for 5 years. And for hypertension, while there is some, having hypertension made your motor function actually a little bit better in the early years, over the 10 years, actually there is no real difference. Hypertension doesn't seem in this case to be affecting motor function. Doesn't mean you don't address it, but it doesn't seem to be, at least in terms of specific to traumatic brain injury, worse than what it is in the general population. But if you look at something like myocardial infarction or heart attack, what you see is there's a very marked difference. And here the red line is the yes, those are those who've had the MIs. And while at first, this could have been any time in their life, while at first they don't look that different from the rest of the brain injury population, as time went on, there was a very marked decline. So MI would be something that we would be saying either if they brought it into the injury, a prior history of heart failure, we would want to be proactive about it, try to minimize its long-term effects, and furthermore, we want to do what we can to prevent somebody from having one after their injury. Both of those are good health, or medical approaches with or without brain injury, but you can see their additional importance for our population. Depression, this is depression ever in your life, before or after your injury, and its effect on motor function here. And you can see that it definitely has an effect, particularly as time goes on. And as you might suspect, depression in this case has more of an effect on cognitive function. And right from the beginning, as a matter of fact, those with a history of depression have poorer cognitive function than others with traumatic brain injury. So that's not news. We know depression is something we want to treat, but we not only should be thinking about preventing it after, but thinking about people with histories before, and maybe ways in which we can be more proactive. So that's just a sampling, and frankly, those, the populations those were based on are small enough that I don't think that we have the last word on any of the conditions that we studied over those 10 years. But that's the kind of thinking that's needed to be able to address the second and third bullets, which is, which other conditions, pre-existing or otherwise, should we be vigilant about? Okay, a fourth issue is how can an individual participate in their self-management? And I've already alluded to the fact that perhaps this is one of the the most important aspects of a chronic disease management model. There's a very well developed approaches for self-management in aging, led by a group out of Stanford. And what they have developed in terms of engaging a person in their motivation to manage the various chronic diseases, whether diabetes or obesity, etc. Teaching them how, and then how to support that over time. In traumatic brain injury, we're not as sure, if the approaches that have been used for other conditions are the same approaches we can use. Questions like, can can people with traumatic brain injury just be fit into the same kind of groups and classes where self-management is taught for other conditions? Or do we need to take a more unique learning approach? And particularly because of some of the effects of traumatic brain injury on cognitive function, this suspicion might be that we need our own methods for engaging and sustaining a person in their self-management. Um, but that might not be the case. It might be that being able to help people avail themselves of resources created for other conditions will be effective. This is absolutely critical that we know how to engage the brain injury field in self-management. And a lot of that will be, the individual and family knowing as much as we know about what kind of conditions to look out for, what kind of preventive things. But it's also, and equally, if not more important, the willingness to lead a brain healthy lifestyle. And that lifestyle is going to include avoiding other traumatic brain injuries, eating well, and though I think eating well means eating a lot, it actually means eating good food, exercising regularly, getting sleep, not drinking alcohol or using illicit drugs, stopping smoking, being engaged with people and projects in one's life, minimizing the stress in your life to the extent possible. Seems kind of ironic to be talking about that today, in this day and age. And finding ways that you can stimulate relaxation, whether that's through meditation, mindfulness, or other techniques to give yourself more control over the ability to, in the moment, really reduce stress. These are all great behaviors for any human being. But I think what we realize is that with a history of brain injury, these become even better advice. And there are nine suggestions here. If you're not doing all nine, you're not going to start them all tomorrow. And so being able to start picking off the ones you can, congratulating yourself for the ones you already do, and then making behavior change over time, so that maybe you're doing 7 of these or 8 of these. That's what will help optimize your long-term functioning. So even as important or more important than the medical approach to chronic disease management, and individual and family members assisting the medical personnel in that, will be the individual and family kind of committing themselves to a brain healthy lifestyle. So a fifth area, and I'm not going to do as much with this one, but is getting access to the right medical and rehabilitation care to reduce those negative outcomes. Already alluded to the fact that if we know a complication's developing, if you can't get medical treatment for it, then if you can't get assistance reducing blood pressure, can't get the afford the medication, whatever, then it has done no good to have identified it early. So making sure that medical care is available over the lifetime and is accessible to individuals is really important. Even more important, or maybe of equal importance, as I've said before, is having access to rehabilitation care. Being able to re-optimize one's functional abilities over your lifetime seems to me to be an essential aspect of long-term chronic disease management. And finally, then, how community-based resources can be used to improve function and reduce institutionalization. This one takes a little more time to set up, and I'm not going to try to as I'm looking at the time. But we have known in the brain injury field that sometimes leaving the hospital is like walking off a cliff. That's getting better in certain states. New Jersey's doing a wonderful job putting more community supports out there. But there's no question those supports need to be across the rest of one's lifetime and not just limited to the early part. And that having those kind of supports, keeping one in the community, both is obviously reduces institutionalization, but it improves function and improves health. So this would be the agenda. We need the evidence that will tell us the answers to these. I don't think that we can wait for absolutely evidence-based practice in all of these. I think that we need to start with best practices and continue to do the research that will allow us to tweak and refine that best practice over time. And to get there, it's going to take policy change. And one of the outcomes of that interagency agreement I mentioned before between NIDA and CDC was creation of this policy fact sheet. It actually covers some of the information we've talked about today and looks at policy implications for researchers, for federal decision makers, state level decision makers, as well as healthcare providers. We are all going to have to get on this bus if this bus is going to go anywhere. It's a very big lift to really change the course of research and resources to accomplish a well designed and effective chronic disease management approach. But we can do it. It's within our reach. And there are things we can do today, whether you're an individual or family member, committing yourself to a healthy lifestyle, working with your primary care provider to identify comorbidities. There are things we can do today, but the goal obviously is that this would be available for all 25,000 Americans who find themselves each year in rehabilitation for a primary diagnosis of traumatic brain injury. So, thank you.
Hello, I just had a question. So you were talking about different diagnoses that have negative effects. Is there going to be a study completed that's going to try to compile as much information about which particular injuries might have the most negative effects? Great presentation, thank you.
Oh, you're welcome. So there have been actually quite a few studies going on, the model systems, but other researchers as well here in the US and in Europe have really kind of pivoted to looking at this, what's behind the long-term course. And the first place many investigators went was to ask about comorbidities. And so there have been a number of studies published looking at different kinds of risk factors for different kinds of conditions. So far, what we would say is that there are both behavioral health and physical health, that it's not one or the other, and that and indeed the two may be related. One of the this winter, Neidler, the funder of the TBI model systems, put out a request for proposals for a 5-year project to develop a chronic disease management approach to traumatic brain injury. The model systems did a collaborative proposal with all 16 centers and VA to address that, to in hopes of successfully competing for that. But somebody will win that, and that will be that will give us some resources to start to fill in more of these questions, everything from comorbidities to some of the other things I raised.
Hi, Dr. Corrigan. This is Laura. I have a few of the questions ready for you. I'm sorry I got thrown off myself, but
Okay.
we do have about 4 or 5 questions. We have about 6 minutes, so I'll try to go through them quickly. A couple
Okay,
of
I'll
them
try to
have
be
to do with
fast.
COVID-19 also. But the first question was, how do providers get the individual to buy into creating a brain healthy lifestyle, or even getting other providers to work as a team to create a brain healthy lifestyle?
The preliminary question is, how does one get humans to engage in a brain healthy lifestyle? And then, then the question that was asked, how do we get folks with brain injuries? Like any behavior change, it's a combination of good information about the necessity, good information about what's needed, and being willing and able to support a person as move towards making that behavior change. If some of these things that we looked at were as easy as just saying, "Oh, okay, I'll do that," and then a switch is flipped and it happens, we would have no behavior. Most of behavioral healthcare wouldn't be needed. I mean, behavioral healthcare is about supporting people to make sometimes quite difficult behavior changes. And so I think that needs to be part of what we are doing systematically, and not just by behavioral health professionals, occupational therapists, physical therapists, our physicians, our speech therapists, our recreational therapists, all have a piece in working with individuals to attain that. But it's like all behavior change: good information, good support, reduce barriers, and allow it to happen over time. Allow time.
Wonderful. I do have about 3 or 4 questions in regards to COVID-19. So would you be able to speak just a little bit about the correlation between people with brain injury and COVID-19?
I don't know if it's possible to speak briefly about that, and it's because the less we know, the longer the answer. But we have both the disease itself, and what I think we're becoming more and more impressed by what we don't know about COVID-19, and its ability to affect various organ systems, including the brain. There's just how much of that is a direct effect of the virus, how much of that is a secondary effect of our immune system, detecting something really bad, and then kind of going off, and there being collateral damage. These are things we just don't know yet. And not only is the brain and the central nervous system in question, but other organ systems as well. It's not just a respiratory problem. But then there's the behavioral aspect of it, and that's what does this response of needing to social distance, to stay at home, the reliance on telecommunications more for our social engagement. These all have special challenges and issues for persons with brain injury, and I think that as a field we should be working on that. I know that some of the survivors who are on our advisory council who have felt isolated already, their kind of reaction to the rest of the world staying at home was, welcome to my world. This is what it's like. But that's not, we can't just say, well, then that's okay. So I think as advocates, professionals, survivors, we need to be addressing the use of telecommunications, the feelings, the fear, the isolation that has come with COVID-19 as a social factor.
Thank you. I would like to thank you, Dr. Corrigan, for your time and sharing with us this wonderful research and information on TBI as a chronic health condition. I know in the beginning we began with a virtual applause, and I'd like to end with one too. So that's for you. And at this time, please, for all of the attendees, now to go back to your email with the links that are enclosed and select your next workshop, which will begin promptly at 10:40. And again, thank you, Dr. Corrigan. Have a great day.
Thank you very much.